Hi friends, welcome to this new video on HIV and AIDS. HIV/AIDS is one important topic which almost every faculty, every subject going to ask you, or may it be microbiology, pathology, pharmacology, medicine, or community medicine. And people would love to ask you questions on like what is the best route from microbiology, mode of transmissions, and National AIDS Control Organization, of course. So let us take this whole topic. I'll give you a comprehensive review on HIV/AIDS for most of your MCQs for the PG entrance exam. So I have divided this whole HIV into various subtopics. So the section 1 in this video will deal with diagnosis of HIV, epidemiology of HIV, diagnosis, and a few topics about clinical features of HIV. So having said so, let us actually start. And in the next video update, we'll be talking of the ARTs, the treatment schedules, and the prophylaxis, and many things about the drugs and pathogenesis of this pathophysiology of HIV. So let me just start it on. And first question is like, first thing is, I think everybody knows this red color ribbon is for HIV/AIDS. It's a symbol for HIV/AIDS. If we talk about epidemiology of HIV, if we talk about the epidemiology of HIV, the amount of HIV in India, the prevalence of HIV is 0.22% in India. It looks like to be fairly low, but of course we have a long way to go forward towards zero HIV. The target of this program, the target of this NACO program is to obtain zero HIV transmission. Next. If you talk about epidemiology, if you talk about the prevalence of disease, the prevalence looks to be 0.22, but this 0.22, India is a big country. It amounts to, do you know that it amounts to 2.14 million people living with HIV, PLHIVs, that is 2.14 million, which actually, this 2.14 million actually boils down to India is the third largest burden sharing community for HIV. That is, the third largest burden is given by the Indian subcontinent. So of course, if you see totality HIV people, out of these HIV people, India does contribute a major share in having this HIV. Next, question number 2. If you talk about the next point, that in HIV epidemiology, that there are two types of HIV viruses. There is HIV-1 and HIV-2. So if you talk about HIV serotype 1 and HIV serotype 2, serotype 1 is having many groups. So there are group M, that is the major group, a new group, and an outlier group. So this major new outlier, that is the group M, group N, or group O. This major group has again many subgroups ranging from A to K and excluding I. I group is not present, subgroup is not present. A to K you have many groups, and out of these the C group is most common. So MCQ, which is the most common type of HIV? Please remember, the most common type of HIV we encounter in India is HIV serotype 1, group M, subgroup C. So the most common is HIV-1MC. If you talk about HIV-2, HIV-2 is a single serotype, but of course you should be knowing a slight things about HIV-2, that HIV-2 serotype, it is a slightly lesser pathogenic. It has slightly longer window period. That is, it causes the clinical features, the presence of the clinical features is particularly delayed, and there is a delayed decline in the CD4 count. So the CD4 count has slow decrease. And because it has a slow decline, when we treat these HIV-2 cases with ART, the CD4 count has a slow regression. So there is a slow response for ART, for CD4 counts with patients on ART. So actually HIV-2, the NNRTIs that we use, is resistant for HIV-2, and therefore it is very important to remember which one is more common. Like HIV-1, are you dealing with HIV-1 cases or are you dealing with HIV-2 cases? So this is about the burden and the basic epidemiology. The next topic is about the mode of transmission. People can also ask us about the next MCQ is regarding the mode of transmission. So mode of transmission, which is the most effective mode of transmission? Effective means which is the most common, or if you're formulating a public health policy, which risk factor you need to cater for. So please remember, the most common route of transmission, may it be state of Assam, may it be state of Maharashtra, may it be state of Delhi or India or the whole globe, the most common route of transmission or the most common mode of transmission or the effective mode of transmission, it is always sexual. Though it has a very low chances of infection, but the most common route of transmission is sexual. Next, they can ask us a question, which is the most efficient. Efficient means if that mode occurs, it will lead to a disease. The most efficient mode of transmission is defined as using blood. So blood has a very high efficiency in transmitting HIV. It's roughly around 80 to 90%, and sexual has only 0.3%. But anyways, please remember, efficient is blood, effective is sexual. So that completes your topics on questions on epidemiology for HIV. HIV, we all know. You should also remember this, a few points about HIV. I would also like to share with you that HIV, if you know, was HIV is a disease which is taken care under the NACO, National AIDS Control Organization. So this NACO was started immediately after we got few cases reporting from 1986 from Chennai, Madras. So in 1986 you get some few cases of HIV, and very soon the government of India, they thought of formulating a national health program under the aegis of National AIDS Control Organization. The program name was National AIDS Control Program, NACP. NACP was started in 1990 somewhere, 1992, and it extended in various phases. The current phase is NACP phase 4, NACP phase 4, and the target of this NACP phase 4 is to achieve a zero HIV transmission. So please remember, which is the most common route of transmission, that is sexual. We want a zero HIV transmission under this new launch program of NACP phase 4. And we are also giving this standard treatment, ART treatment, which we shall discuss in the subsequent videos. But I would like to inform you that under the Sustainable Development Goals, the target for the NACO, the target for AIDS control is 90-90-90 strategy. What is this 90-90-90 strategy by the Sustainable Development Goals? Sustainable Development Goals. So what is this 90-90-90 strategy? The first 90 means that out of the total chunk of HIVs, 90% should actually be diagnosed and brought to the public health system. So there should be accountability of the public health system to 90% diagnose. 90% of all HIV people should be diagnosed. Out of those who diagnose, out of them, 90% should be put on treatment. That is, the ART should be provided to at least 90% out of the total people who are HIV. Out of those who are taking treatment, out of them, at least 90%, at least out of those who are taking treatment, at least 90% should be having a effective treatment. There should be a viral replication should be stopped. There should be a viral load remission. There 90% should have adequate response to the treatment. Adequate response to the treatment. In terms of what? In terms of viral load remission. It's important. Why? Because try understanding that if you formulate a national health policy, that I will commit myself, we'll commit as a government, as a public health agency, we shall commit that out of all the HIV people, 90% we're going to take under this HIV, and we'll diagnose them. Out of those who are diagnosed, 90% shall be put on treatment, treated, will have adequate viral remissions. That means you should have a system to check for viral load remission in every state, in every district. So that's what is important for us to understand, that now for progression of disease, or in other words, the response to ART is best assessed by options are CD4 count or viral load. You will answer viral load. Few years back, this was not the case. So there are a couple of changes which this program has built in. That earlier we used to take CD4 as a marker for response to ART, but now we do not take CD4 count. We take the viral load or the viral load as an important marker, right? So these are a few introductory points which have been changed under this, which have been brought into more noticeability under this NACO program, National AIDS Control Organization Updates 2018. Next we shall take is about the how to diagnose. So now let's talk about the diagnosis of HIV. If we talk about the HIV diagnosis, there are a couple of things you need to know beforehand, that the government of India has set up something known as ICTC centers. What are ICTC centers? ICTC are integrated counseling and testing centers. So at these integrated counseling and testing centers, we have some NACO approved investigations, which are rapid tests. So which are the NACO approved rapid diagnostic tests? Which are the NACO approved rapid tests? I won't say diagnostic, because all these tests which I'm going to tell you, they have roughly around more than 99% sensitivity, whereas roughly around 90 to 95% specificity. They are highly sensitive, but they are somewhat nicely specific as well. So if they are sensitive, that means these are usually taken as a screening tools. But if you combine various tests in modality, they might become specific as well. So we'll just see. There is slight complications over here. So which are the NACO approved rapid diagnostic tests, or the screening tests, whatever you want to say. The NACO approved rapid tests are: first, enzyme immunoassay. Second is immunochromatography. Third is immunoconcentration method. Immunoconcentration method is nothing but what we commonly call as dot and blot method. This is dot and blot, is like you put a dot and it vertically flows. So it's also known as, some people in your exams might also call it as a vertical flow method. It might be known as a vertical flow method, and chromatography is what is a lateral flow. So it goes like laterally, and then you have a vertical flow method. So you have these. Fourth is particle agglutination method. So you can just remember there is an immunoassay, chromatography, concentration method or a dot plot method, and an agglutination method. So immunoassay, chromatography, concentration, agglutination. These are like four usually taken up modalities under ICTC as rapid investigations. You can, in your ICTC, you can use any of the following in the first test, and then the second, and then you take up the third or the fourth. Usually we take up immunoassay as the first investigation. So how do we diagnose? So for diagnosis, let me simplify it for you. Remember, I'm trying to actually condense a 280-page guideline for you for your MCQ exams. So if you talk about diagnosis of HIV, I can help you in simplifying the whole stuff in just two things, that the diagnosis is either for symptomatic individuals, or you can have for asymptomatic individuals. So in case it is symptomatic, that means they're showing some signs and symptoms. We shall discuss them later. Some signs and symptoms like they could be like features of pneumonia, meningitis, hepatitis, or they could be simple features of oral thrush or genital ulcers, or they could be candidiasis, or nothing at all. It could be simple lymphadenopathies. So these patients might be symptomatic with fever, diarrhea, or these features, or they might be asymptomatic. In case they are symptomatic. Now, what do we do? So let me take the first scenario of in case they are symptomatic individuals coming to an ICTC center. If they are symptomatic, we will do the first investigation. We will do the first investigation that is called as A1. Okay. So we will do the first investigation that is A1. Now A1 can be positive, A1 can be negative. If it is A1 is positive, if this A1 is positive, that means we shall do something. But if it is negative, please remember this is declared as HIV negative. If the first assay is negative, it is HIV negative. That's what is take home message. If the first assay is negative, it is HIV negative. So this patient is declared as HIV negative. Now the problem starts that sometimes what happens is patient is SA1 positive. In those cases, we are supposed to send this patient for A2 as well. You do a A2 assay. A2 can be positive, A2 can be negative. If this A2 is positive, that means what is this person? This person is, can I say he is A1 positive? He is also A2 positive. If this patient is 2 positive on 2 tests, it is unfortunately declared as HIV positive. This patient is declared as HIV positive. What is HIV positivity? You will do 2 tests and both the tests are positive. Now in case we have A2 that is negative, so that means what? A1 was positive, A2 is negative. If A1 is positive, A2 is negative. Now we are supposed to do another test that is A3. So please remember, you do the first test. If it is positive, you do the second test. If it is positive, HIV. If it is negative, do A3. Simple. If you do the A3, A3 can be positive, A3 can be negative. If the A3 is positive, that means what? What do I call this patient? This patient is A1 positive, A2 negative, A3 positive. A1 positive, A2 negative, A3 positive. This patient is known as HIV indeterminate. This is HIV indeterminate, right? So please remember that what is HIV indeterminate? HIV indeterminate is if it is out of 3 tests, 2 is positive and 1 is negative. Okay. A1, the first test is positive and the last is positive and middle was negative. This is indeterminate. You do not label it as HIV. This is not HIV positive. What we do with the indeterminate, that is a separate point of discussion. But right now, please remember this is indeterminate. Next, what do you do to this patient? If in case this is A1 positive, A2 negative, right? A2 was negative, right? A2 was negative as you can see. And A3 is again negative. So out of the 3 tests, 2 are negative, only 1 is positive. This patient is declared as HIV negative. This patient is declared as HIV negative. So you don't need to worry about this patient who is HIV negative. So in spite of the fact that there was 1 assay which was positive, so don't worry, in spite of the fact that he was symptomatic. If it is 2 assay negative, out of 3, this is HIV negative. So what we do to these positive negative, that is a separate story. We'll discuss that later. So that's how we talk about these symptomatic cases. Okay, next. Let's talk of the asymptomatic cases. Now asymptomatic is slightly more ethically challenging and slightly a little complex phenomena. So just try to understand with open minds. You do the first test, that is the A1. If this A1 is positive, or this A1 could be negative. If it is negative, that's very simple. Patient is very happy. Patient is the happiest person because he is HIV negative. If the first assay is negative, either symptomatic or asymptomatic, if the first assay immunoassay, enzyme immunoassay, ELISA method, if it is negative, that means we declare the patient as negative. The problem starts if this enzyme immunoassay is positive. If the enzyme immunoassay or the first test SA1, this is SA1, if that you do, if that becomes positive, now you are going to send this patient for A2. If you do the A2, this A2 can be positive or A2 can be negative, right? If it is positive, if this A2 is positive, in spite of whatever the result, what is this patient? He is A1 positive and A2 also positive. Are we fine, right? This is A1 positive, A2 also positive. We do not declare this as HIV. You remember in symptomatic, A1 positive, A2 positive, this is symptomatic, this is HIV. But in asymptomatic patients like you and me who are healthy, if we go to an ICTC center, A1 is positive, A2 is positive, then to reconfirm, we need to send this patient for A3. You cannot declare them as HIV until unless you have the A3 result. A3 could be positive, A3 could be negative. If the A3 is positive, that means what is this case? This is A1 positive, right? A2 positive, A3 also positive. Now this patient who is A1 positive, A3 positive, A2 positive, everything positive, this is known as HIV positive. This is unfortunately HIV positive case. It is declared as HIV positive. So what is asymptomatic HIV positive? All three tests to be positive. SA1, SA2 and SA3. Now in case you have this scenario that this is, what is this? A1 positive, A2 positive, A3 negative. In case you have A1 positive, A2 positive and A3 negative, now this patient is not known as HIV positive. This patient is known as indeterminate. This patient is known as indeterminate. Okay, so what is indeterminate? Out of the 3 investigations that we do, in case you get 2 positive and 1 negative, that is known as indeterminate. What you do to these cases, to these people who are HIV negative, what do you do to them? So not HIV negative, A2 negatives. You do A1, A1 is positive. Now you do A2, A2 becomes negative. Now if A2 is negative, that means what is this case? This is A1 positive and this is A2 negative. Now to these patients, A1 positive, A2 negative, of course, again you need to test them with using A3. This A3 could be positive or this A3 could be negative. This A3 could be positive or this A3 could be negative. If this A3 is positive, that means what is this? This is A1 positive, A2 will be negative and A3 is positive. So what is this A1 positive, A3 positive and A2 negative? That means out of 3 investigations, 2 are positive and 1 is negative. This patient who was asymptomatic, you cannot label him as HIV. This is also termed as indeterminate. It looks like the other one, just what we did in the other one. As you can see, A1 positive, A2 positive and A3 is negative. This is what is indeterminate. Now in case you have A3 as negative, that means what is this case? This is A1 positive and A2 negative and A3 also negative. Now in case it is A1 positive, A2 negative, A3, out of the 3 investigations, 2 are negative, only 1 is positive, slightly positive. Now you don't label it as directly HIV negative. You have to see whether they are high risk or you see whether they are low risk. If they are from high risk category, they have some previous infections, they are intravenous drug abusers, commercial sex workers, they are from high risk population, we label them as intermediate. Try understanding, if there is a asymptomatic case from high risk population, if they are coming to you from ICTC centers, out of the 3 investigations, any one is positive, that is indeterminate HIV. But if they are taken as low risk, this is declared as HIV negative, right? So that's it for asymptomatic cases. So asymptomatic, you have this plethora that you can have HIV positive, you can have HIV negative or indeterminate results. So I hope it makes sense to you that in case of HIV, in case of asymptomatic individuals, you need to be slightly more cautious on how to tackle these patients, right? So now, what do we do to these HIV people? To the people who are HIV negative, nothing to be done, they are enjoying their life. People who are HIV positive, we take care of them by calling them by confirming using a after a confirmatory test using Western blots or using RT-PCR techniques, and we start with ART. That's another story. But what do we do to these indeterminate people? People who have indeterminate results. People who have indeterminate results, we have to, nothing very big, we have to repeat the assays in different sample. Remember all the assays that you had done before, assay 1, assay 2, assay 3, all these assays that you had done right now, they are all done from a single sample. But in case it is indeterminate, you repeat the sample and then you redo it. By repeating the sample and doing it, when do you do? Only after 14 till 28 days. So after a month or so, we repeat it because that's a window period, and then you recheck them again and then you diagnose them again. Remember the four criteria for investigation: the immunochromatography, immunoconcentration method, immunoassays, and the agglutination method are approved. And for diagnosis, as you can see on the screen, you have symptomatics, asymptomatics. For symptomatics, you do test 1. If it is positive, you do the test 2 to confirm. If it is negative on test 1, it is HIV negative. If the patient is asymptomatic, no symptoms, you do first test. If it is positive, if it is negative, job done. It's happy. HIV negative. If this HIV test is SA1 is positive, you do the test 2. Whatever the result is, you do the test 3, and then you see if all 3 are positive in this asymptomatic case, only then you declare him or her as HIV positive patient. In all indeterminate, you take for repeat after 14 till 28 days. So that covers almost everything regarding your diagnostics. So the next we can take up is about the clinical features of HIV. The clinical features of HIV, you can all understand that in clinical features for HIV, we have divided into stages for simplicity's sake. We can have stage 1, stage 2, stage 3, and stage 4 of HIV based on the symptomatology which is presented by this patient. So you can take it for your exams that we have divided into stage 1, stage 2, stage 3, and stage 4 HIV. So there are like 4 stages. So what is this stage 4? All these that I'm going to tell you is for adults and for adolescents. What is adolescent according to the NACO program? The adolescents are same 10 to 19 years. So we are talking of the adults or the adolescents and not about the children, because pediatric TB will take in the video number 3 actually for HIV updates. So this is your video number 1 by 3. So this is like clinical features of HIV. Stage 1. Stage 1, the patients are usually asymptomatic. They will not have any big signs and symptoms. So they are generally asymptomatic, or at the max they would be having like generalized lymphadenopathies. Generalized lymphadenopathies is the only thing that you might find in stage 1. Otherwise, predominantly these patients are asymptomatic. In stage 2, these patients are going to present with us some mild infections or surface infections or skin infections. So if the patient is having some skin infections, surface infection, that is stage 2. What do I mean by skin infection? We mean that sometimes these patients might present to us with features of like oral ulcers, herpes infection. Herpes infection, mind you, of less than 1 month duration. It should not be like lingering on for more than a month, because that indicates opportunistic infection. That indicates a immunocompromised status of the patient. So this is herpes infection, which could be like less than a month duration. Oral ulcers, or we can have like genital ulcers. Some skin infections like zoster infections, angular chillosis. All these are characterized under stage 2. In case there is a weight loss, this is usually associated with a moderate type of weight loss. There is no severe, there is a moderate weight loss. What do you mean by moderate weight loss? Moderate weight loss is weight loss of less than 10% of your body weight. So usually if it is less than 5% of the body weight, if a 70 kg person comes and says that I've lost 5 to 6 kgs in a couple of months, so that's like mild to moderate weight loss. So if it is like more than 5%, we call it as moderate, and less than 10% is moderate, more than 10% we call it as severe. So moderate is more something around more than 5, but definitely less than 10. So it is a moderate weight loss with these surface skin infections like zoster. There could be some nail infections or nycolitis or skin infections predominantly on the surface. Third is, like, you can remember for your exam, as organ involvement. What do you mean by organ involvement? The liver will be involved. Like hepatitis, there would be features for from hepatitis, or we can have, like, patient can have meningitis or any organ involvement for that matter. There could be features like pulmonary tuberculosis. Please remember, pulmonary tuberculosis is the most common. There is a lateral MCQ on this. Please remember that pulmonary tuberculosis is the most common opportunistic infection. It is the most common opportunistic infection, but predominantly opportunistic infections are in stage 4. Pulmonary tube, all opportunistic infections will be taken under stage 4 except pulmonary tuberculosis. Pulmonary tuberculosis is the most common opportunistic infection. We take it up in stage 3, HIV. So this is about a few other like patient can have pneumonias. Please remember, I'm not saying pneumocystis carinii pneumonia. Don't always think that HIV PCP pneumonia. No, like, which is the most common? 40-year-old male presenting to emergency room with the features of fever or respiratory illnesses. What is the most common pneumonia you would think of? You'll think of strep pneumonia. That is a community acquired pneumonia. Or you'll think of Kleb pneumonia, or you'll think of staph pneumonia in intravenous drug abusers, right? So these are the pneumonias which are predominantly common in stage 3, and these patients would be categorized under stage 3 of HIV. So pneumonias, pulmonary TB, severe bacterial infections, or there could be unexplained weight loss of more than 10%. That is, it's a severe weight loss. And there is anemia, unexplained blood loss, anemia, hemoglobin of less than 8 grams per deciliter, which is like anemia of unknown, like you no explanation for this, unexplained anemia, unexplained weight loss, severe weight loss. All these are features of stage 3 HIV. Stage 4 HIV. When would you classify a patient into stage 4 HIV? Stage 4 HIV, if is there, when we call it as something known as AIDS related HIV wasting syndrome, AIDS related complex, or HIV wasting syndrome. Please remember that if I talk of fever in stage 3, as you all also know, that there is persistent fever, or there could be chronic diarrhea, or there could be severe weight loss, right? We have already talked in this. There could be fever or diarrhea or weight loss. But what is this HIV wasting syndrome? That is characteristic of stage 4. In stage 4, you have HIV wasting syndrome, that is fever with the diarrhea with weight loss. All these congregation of symptomatology together in a person is going to present as a HIV wasting syndrome. This is what is fever, persistent fever with diarrhea with weight loss, severe weight loss. All this within 1 month, less than 30 days or less than 1 month duration. That is known as HIV wasting syndrome. Plus, this patient might also have some opportunistic infection. Which are the opportunistic infection which we are thinking over here? The opportunistic infection which we are thinking over here are cryptosporidiosis. We can have isosporiasis, or we can have opportunistic infection like pneumocystis carinii pneumonia. Now it is known as not carinii, now we call it as Gerovicii. Pneumocystis Gerovicii pneumonia, or carinii is the old name, cryptosporidiosis, isosporiasis, or we can have some organ involvement candidiasis, so tracheal candidiasis, or we can have esophageal candidiasis. All these are features of opportunistic infection. Then there is some plethora, and there could be one more opportunistic infection is human papillomavirus, HPV infection causing invasive cervical cancers. So invasive cervical cancers caused by HPV virus infection. especially HPV 16, HPV 32 is associated with these HIV viruses. And then there is some malignancy. Third section under this HIV stage 4 will be regarding malignancy. So what we have done in stage 4 is three things. I've told you one about HIV wasting syndrome, second is about opportunistic infection, and third is about malignancies. What are the common cancers or malignancies that you get in HIV? If you talk about the malignancies that you get in HIV, which is the most common cancer, it is not Kaposi. If you're thinking malignancy, most common is B cell lymphomas. These are B cell lymphomas from the CNS. B cell CNS involvement, B cell non-Hodgkin lymphoma is the most common cancer in HIV. Or we can also have some Kaposi. Your favorite answer is Kaposi sarcomas, or there could be cervical cancers. So you can have some like more cancers, or there could be hepatocellular cancers. So there is predominantly slightly more chance of having these malignancies associated by infections or by the virus per se, right? So this is what we have as staging of clinical features for this HIV disease. And these are like most commonly asked questions, that how do we stage them. So just remember, nothing happened stage 1, asymptomatic. Surface infection stage 2, organ involvement, deeper tissue involvement stage 3, infections, opportunistic infection or malignancy, that is stage 4. Remember, extrapulmonary tuberculosis, pulmonary tuberculosis, that is stage 4. Pulmonary tuberculosis stage 3. Disseminated tuberculosis, that is stage 4. Okay, so that completes your features, clinical features of HIV. Now if you talk about a small point about the energy requirements or about the nutritional requirements in HIV, in people living with HIV. So in PL-HIVs we need to have a concern regarding the nutrition as well. So obviously it's a common sense to understand. So just two MCQs on this. What do you think? Is it low energy requirement or is it a high energy requirement disease? It's definitely a high energy requirement disease. We'll talk of how HIV actually attacks your T helper cells, about your CD4 counts. It actually uses all your energy. So energy requirement is increased by roughly around 10 to 20%. Energy requirement is increased. It's a high energy disease, and because you require, the PL-HIVs require more nutritional demand, it's a nutritionally challenging disease, so you need to compensate them for the extra energy. How will you give them? You'll give them more proteins, you'll give them more fats. So how to give them more proteins? You increase the dietary daily protein requirement. How much? 1.1 to 1.2 grams per kg per day is the protein increase. Second, you can also increase the amount of fat intake. How much fat you will increase? The PL-HIVs will require fat in tune of 20 to 30% of the dietary intake they take. Of the daily diet they are taking, out of the total diet, 20-30% should be fat. For you and me, in all the non-HIV cases, for you and me, general population, it's 10 to 30%. So PL-HIVs, there's slightly increased higher amount of fat intake, 20 to 30% fat. Out of this, roughly saturated fats should be roughly around 7% or less than 7%, we should say. The unsaturated component, that is the MUFA, should be more than 10%, and the PUFAs, polyunsaturated fat, should be roughly around 10%. So that comes out to be 25 to 27%. So that's the nutritional requirement for these people living with HIVs, and that's how we classify these patients based on stage 1, stage 2, stage 3 of HIV, and that's the way to diagnose. We have finished off diagnosis, the basic introduction, and the basic epidemiology of HIV, and we have discussed medicine in this module. Right, so in the next video we shall be discussing almost everything regarding how the HIV attacks the CD4 cells, what are the drugs, at what level are they acting, which is the ART regimes which are approved by NACO for post-exposure prophylaxis, and for chemoprophylaxis in people living with HIV, chemoprophylaxis from other infections like You can have CPT prophylaxis, you can have like PCP pneumonia prophylaxis, INH prophylaxis. So there are many things to be discussed regarding treatment and management of these cases, which we shall discuss in the upcoming next video module. Thank you so much for watching this video. All the very best.